Hi, this is Dr. Izadi from Pristine Wellness Center, and here I'm trying to squeeze a 3 hour presentation to 1 hour video for every woman in order to make an informed decision regarding hormone replacement therapy, which is very critical. And I encourage every woman, any age, to watch this 1 hour video and know exactly what they need to do when they approach menopause, or even women after menopause need to know the information to know what to do to get rid of their symptoms. The symptoms of menopause, we can have vasomotor instability such as hot flashes, night sweat, fatigue, impairs sexual activity and desire. The top problems regarding menopause are cardiovascular disease, dementia, memory loss, poor concentration, and osteoporosis. These are all um, debilitating side effects of menopause that can be prevented. Depression, anxiety, mood instability, these are all the side effects of menopause. Sleep problem. And also, women start craving for food, weight gain, hair loss, more wrinkles on the skin. These are not normal aging. These are the side effects of hormonal deficiency that can be prevented. When we have thyroid hormone deficiency, we replace it with the same thyroid hormone. And there is no reason not to be able to replace hormonal deficiency during menopause with the same hormones that are chemically and physiologically similar to our own hormones. Why should we treat menopause? Because women die from heart attack 7 times more than breast cancer. The risk of breast cancer is higher after menopause. Alzheimer, memory loss, poor sex life, joint pain, muscle ache, losing muscles, wrinkles, fracture, all these are involved in deteriorating the quality of life that can be prevented or treated. Why is it so scary to use hormones? Why is in even to this day in 2019 they make women afraid of hormone replacement therapy with the fear of breast cancer and heart attack and Alzheimer? And these are all credible sources. Cancer.net, Scientific America, they all refer to the meta-analysis Cochrane review in Lancet in 2019, which we go over that. So what is the Cochrane review 2019? It was published in JAMA, and most of the studies that they refer to in their meta-analysis are WHI and HERS studies. WHI is Women's Health Initiative, which cost almost $1 billion. And the base for this study, the same for HERS study, were wrong. The study design was wrong, and it's not helpful, useful for women to get any help, any guidance from these studies. Why? Because the type of hormones that they used in WHI and HERS study were conjugated equinestrogen and medroxyprogesterone acetate. I go over all these different type of hormones because it's very important to know what they are and what are the differences. The HERS study, heart and estrogen progestin replacement study, was in women in menopause, mainly over 70 years of age, with established coronary heart disease. These were women who already had myocardial infarction, heart attack. They had cabbage, they had angioplasty and uh, high lipid panel and all the risk factors. So when you do a study on women with already established heart disease, they put these women on conjugated equine estrogen, oral estrogen. And to me, it was even unethical to run a study like this because oral estrogen increases the risk of clot formation. And these poor women already had coronary heart disease, and they gave them oral estrogen and progestin, medroxyprogesterone acetate. They both increase the risk of heart disease, and they wanted to have a reliable conclusion. No way. The conclusion was that no overall effect of 4.1 year of hormone replacement therapy for secondary prevention of coronary heart disease in postmenopausal women. How can we use this information? This study design was wrong to start with, and it was, to me, unethical. This is what we see every day in social media, in credible resources for women. They keep talking about breast cancer, heart attack, Alzheimer, and these are risks of hormone replacement therapy based on what they say. And the base for their statement is Women's Health Initiative study. And that study was wrongly designed, and we go over that together. And womenshealth.org, this is the source that women go to find out what to do with their health issues, how to help themselves. This is January 2019, and this is what they published. Again, they refer to WHI study, and they discourage women from hormone replacement therapy. Menopause hormone therapy and breast cancer risk, Lancet, 29 August 2019. This study in Lancet was a meta-analysis based on studies at WHI and HERS. And the design was wrong. The conclusion was not helpful. And even in August 2019, they are still referring to those studies. So, why should we even pay attention to this? They keep making women afraid of hormone replacement therapy. At the same time, they encourage using oral contraceptive. Oral contraceptive for perimenopausal women. This is from womenshealth.org. What is an oral contraceptive? The type of estrogen is oral estrogen that increases the risk of heart attack, clot formation, stroke, deep vein thrombosis, and it's not helpful with the side effects of menopause. The type of progesterone are progestins that are different from our own progesterones chemically and physiologically. Why do they encourage women to use oral contraceptive and not to use hormones that are the same as our own hormones? There are two major resources for women to get information regarding menopause. One is North American Menopause Society. The journal from this society is the Menopause Journal. The website is menopause.org. This organization was founded in 1989. It's a nonprofit organization, and the goal is improving the quality of life for women. And the other one is International Menopause Society, based in UK, but 62 countries are involved. and it was founded in 1978. The journal from this society is Climacteric. So I refer to these two journals frequently during my talk because I want to show you that even credible resources for conventional medicine have the same conclusion that I have, and there is no reason for women to be afraid of using hormone replacement therapy. What is the fear? Where is the fear coming from? It's WHI study. This study was done in started in 1993 to 1998. They started recruiting women, and they recruited over 150,000 women. But you need to know that only 30% of participants were 50 to 59 years of age. Most of them, 70% of patients, were over 60 years old, and most of those patients were 70 to 79 years old, and they already had health risk factors like obesity, smoking. They were either current smokers or previously smokers, had history of smoking, hyperlipidemia, you name it. They had all different issues, and they were more than 10 years beyond menopause. So this is one bias. Another bias is the type of hormone that they were using. The study stopped in 2002 because they noticed that there was increased rate of breast cancer in those women. And then in 2005, they stopped the other arm of the study because of increased risk of stroke and heart attack. And we go over all of these and see what was the reason for those manifestations. So the WHI study is not helpful. It has a lot of bias. The design was wrong, and it does not help physicians to make any decisions based on WHI study. In WHI study, there were 4 groups of women. Two main one were on either conjugated equinestrogen or conjugated equinestrogen and medroxyprogesterone acetate. And for each arm, there was a placebo group. So when we say conjugated equinestrogen, this was the type of estrogen that they got from the urine of the pregnant horse. I'm puzzled. Why did they choose horse? We know that scientifically, physiologically, we are closer to monkeys. I don't know why they didn't choose monkeys. They chose horses, and they got estrogen from the urine of the pregnant horse. And they are still using it to this day. In that hormone, the urine, there are over 8 different types of estrogens that belong to horses. We do not even have those hormones in our bodies. And over 70 to 80% of the estrogen that is in conjugated equinestrogen, CEE, is estrone, the bad type of estrogen. In our body, we have 3 different types of estrogen: E1, which is estrone; E2, which is estradiol; E3, which is estriol. The estrone E1 is the one that causes breast cancer because estrone converts to 4-hydroxyestrone and quinones are carcinogens, known carcinogens. So when we give the patient CEE, conjugated equinestrogen, we give them, first of all, the bad type of estrogen that causes breast cancer. Second of all, different type of horses estrogens that we do not even have in our body. Let's go to progesterone. Medroxyprogesterone acetate, MPA, has nothing in common with the progesterone that we produce in our body. Chemically, the structure of the hormone is different. Physiologically, it has a different effect in every cell in our body. So choosing conjugated equinestrogen and medroxyprogesterone acetate to treat menopause is a wrong design. Now, during this talk, I mentioned bioidentical hormones. By using bioidentical hormones, I mean hormones that are chemically and physiologically similar to our own hormones. And I do not use as much as I can unless in very exceptional cases, I do not use compounding hormones because there is no control and regulation by FDA on compounding hormones, and we don't know what we deliver to the patient. So, fortunately, these days there are FDA approved and supervised bioidentical hormones that we can use. The estrogen patch, the best type of estrogen that we can use, the micronized progesterone, and there is no reason to go for bioidentical hormones. Now, there are multiple studies in France, Italy, and China, and many other countries comparing bioidentical hormones with conjugated equinestrogen and progestins, including medroxyprogesterone acetate, and they show the difference. So that's why relying on WHI study or HERS study is not a reasonable decision. What is Premarin? Premarin is the conjugated equine estrogen from the horse's urine. As I said, 80% of it is E1, and the rest is different type of horse's estrogens. And this type of hormone was used as the main hormone from 1965 to 2005 in Prempro. Prempro was combination of Premarin, which is the estrogen from horse, and Provera, which was medroxyprogesterone acetate, which has nothing in common with our progesterone. So why shouldn't we use oral estrogen? There are oral types of bioidentical estradiol, but we should not use that. Why? Because when we take estrogen oral, it has to go through the liver. It can increase the risk of inflammation, clot formation, increase the risk of thromboembolism and heart attack, stroke, and it's pro-inflammatory. And it also causes stone in gallbladder, cholecystitis, and we can avoid these side effects and get even more benefits by using transdermal estradiol. This was a study from Atherosclerosis Journal in 2003. They compared two groups of women, one on oral estradiol, which is bioidentical hormone, one on transdermal estradiol, and they followed them for 28 days. Now, this is a short study, but there are many studies, longer follow-up, including E3 and French study, that show benefit of using transdermal and the harm of using oral estradiol. So oral estradiol increases this C-reactive protein and it's pro-inflammatory. Estrogen E1 is one of the three types of estrogen that we have in our body and is the one that converts to 4-hydroxyestrone. And this 4-hydroxyestrone if we do not detoxify our body from it, converts to quinone, and quinones are known carcinogens. This is how we get breast cancer. And when we have extra fat in our body, the aromatase enzyme in our fat cells converts androstenedione to estrogen. When we are in menopause, we do not produce estrogen from ovaries anymore, but our adrenal gland keeps working until we die. And androstenedione is one of the hormones that we produce from adrenal. And when we have extra fat, the aromatase enzyme converts that to estrogen and increases the risk of breast cancer. This is why being overweight is a risk factor for breast cancer. Another risk factor for breast cancer is dysbiosis. Dysbiosis, when we have the type of bacteria that increases an enzyme named beta glucuronidase, this enzyme detaches estrogen from glucuronide, which body is trying to get rid of. And it increases the level of estrogen in our body, again increases the risk of breast cancer. So when we metabolize hormones and we try to detoxify, the E1 estrogen gets attached to glucuronide in order to get to the stool and excrete from a stool. When we have bad bacteria in the intestine producing that enzyme, and we make the estrogen free, that free estrogen reabsorbs and goes to our body and starts making quinones again. And this is why taking the supplement calcium D-glucarate helps to prevent breast cancer by decreasing the level of estrogen with this mechanism. And that's why every patient who's on hormone replacement therapy needs to be on calcium D-glucarate, indole tricarbinol, and DIM, because these three supplements decrease the level of estrogen and help to detoxify the body and help to prevent breast cancer. Conjugated equinestrogen, again, this is horse's estrogen. And many of these hormones, we don't even have this in our body. Why should we take these hormones? WHI study and HERS study, HERS, we go over that. In these studies, they used medroxyprogesterone acetate and conjugated equinestrogen. There were 14 studies on conjugated equinestrogen. 7 of those 14 showed no benefit of using it. 3 showed harm, including WHI study. And there is no reason to use it. Estradiol, E2. This is the type of estrogen that we need. And we use the transdermal form of it. Why? Because there were 20 studies showing benefit, showing the effect on cognition. 15 out of those 20 showed benefit. And from those 5 that didn't show benefit, 3 of those 5 used oral estrogen, oral E2, and very low dose of topical patch. And this is why optimization of hormones is important. Every patient needs a different dose of hormones in order to optimize their hormonal level. And there is no one dose for every woman. And this is why we need to check the level of hormones frequently, because if you give the patient the right type of hormone, topical estrogen, but the dose is not high enough, you don't get the benefit. There was no harm associated with estradiol, especially the topical transdermal one. So, there are studies in basic science showing that estradiol is protective against Alzheimer and memory loss. And this is a fact in science. Progesterone. There was a study in 2007 from breast cancer research. This study was done in monkeys. About time. Monkeys are closer to human than horses. So this study was done in monkeys. They had two groups of menopausal monkeys, one on um, medroxyprogesterone acetate, the other one on micronized progesterone. And they noticed that only the ones on medroxyprogesterone acetate had breast cancer and change in the um, breast tissue, showing the precancerous lesions. And again, when I use bioidentical hormones, I mean FDA approved hormones that are chemically and physiologically similar to our own hormones. And as as much as possible, I do not recommend or use compounding hormones because there is no regulation. Micronized progesterone acetate versus micronized progesterone. There were studies in 2008, 2009, 2011 showing that um, medroxyprogesterone acetate blocks the estrogen upregulation of the brain mitochondrial function. This is very important. Mitochondria is the battery for each cell. When we block the upregulation of mitochondria in the brain from estrogen, we have memory loss, we have Alzheimer. And on the other hand, micronized progesterone, which is bioidentical hormone, increase the BDNF. BDNF is brain derived neurotrophic factor. It's a type of protein that is protective against memory loss and Alzheimer. And this is why it's important to use the right hormone. Again, this was the study in monkeys, and there was also a very large study in France. There is the E3N cohort study, and in this study, they showed that different type of hormone has different effect on breast tissue and risk of breast cancer. This was a study published in Endocrinology in 2006, and it showed that using transdermal estrogen does not increase the risk of clot formation and heart attack. And this one keeps a study. It's also a very important study, and everybody should know about that. The Kronos Early Estrogen Prevention Study. This study was also a randomized control trial, means that they had a placebo control group and the patient group, double-blinded study, 4 years on patients 42 to 58 years old, which were within 6 months to 3 years of menopause. There were two groups, one on conjugated equinestrogen, the other one on transdermal estradiol. So this study compares transdermal estrogen with Premarin. And both groups were on micronized progesterone because they had uterus and they needed progesterone to protect against uterine cancer. I have to mention that usually they recommend using progesterone if the patient has uterus. If the patient had hysterectomy, there is no need to use progesterone. I don't agree with that because progesterone has over 200 functions in our body, and regardless of having or not having uterus, taking progesterone is beneficial in menopausal women. But if the patient has the uterus, we need to use the oral micronized progesterone to protect against cancer. And if there is no uterus, the patient had hysterectomy, the topical progesterone is another option, because there are no studies proving that topical progesterone can be protective against uterine cancer. In this study, over 700 women were enrolled for this study, and the result was impressive because um, there was benefit for memory, for protection against breast cancer, and all other benefits of hormone replacement therapy. And they also had PET scan uh, investigating the effect on brain and amyloid formation. Amyloid is the main marker of Alzheimer's disease, and they showed that transdermal estrogen actually protects the brain against Alzheimer's disease. This was just a month ago from Alzheimer Association International Conference. Dr. Zayden, one of the researchers at KIPS study, was interviewed and mentioned that transdermal estradiol is protective against Alzheimer, and said that we can say that sleep quality and transdermal estradiol during early postmenopausal years somehow interact to influence beta amyloid deposition, preservation of dorsolateral prefrontal cortex volume and attention and executive function, meaning that transdermal estrogen is protective for the brain and improving the quality of sleep, which is very important in every aspect of our health. This was another study called ELITE, Early versus Late Intervention Trial with Estradiol, and it shows the importance of starting hormone replacement therapy very early or even during perimenopause in order to get the benefit of hormone replacement therapy. So WHI study was stopped in 2002 because of increased risk rate of breast cancer, and the estrogen only arm stopped in 2004 because those patients had increased rate of heart attack, stroke, deep vein thrombosis, and they keep reviewing the charts, following up those patients who are still alive, and giving different results from their study. The oldest study said that conjugated echinoestrogen and medroxyprogesterone acetate, Prempro, increase the risk of Alzheimer. So initially they told women that, oh, don't take hormones. You get Alzheimer, you get heart attack, you get a stroke, and you get breast cancer, and you will die. Well, no wonder women are afraid of hormone replacement therapy. But in September 2017, this was what they published. Conjugated echinoestrogen alone for 7.2 years decreased risk of Alzheimer's disease at 18 years of cumulative follow-up. And even when it was used with medroxyprogesterone acetate, there was no increased risk of Alzheimer. Well, previously you scared every woman of getting Alzheimer and staying away from hormones. And with the same study, same hormones, you change your statement. This study design from the beginning was wrong, and there is no value of referring to these studies, in my opinion. And initially they said that hormone replacement therapy causes lung cancer, and then when they looked into the sample of patients, yes, those patients were mainly 60, 70 80 years old with history of smoking, or they were current smokers, and that's why they had lung cancer. It had nothing to do with hormone replacement therapy. And there was a conclusion that hormone replacement therapy is not protective against colorectal cancer. Well, there are other studies showing that the right type of hormone replacement therapy, it is protective against colorectal cancer. And again, this was 2006. JAMA, they were looking at WHI study. They changed the statement. 2013, again, they said that, oh, the reason that women had increased risk of breast cancer was medroxyprogesterone acetate. And in women who were 50 to 59 years of age, the overall absolute risk was very low compared with those 70 to 79-year-old women who started hormone replacement therapy. Again, the type of hormone was wrong. The selection of patients was wrong, and to me, there is no value in these studies to guide physicians for hormone in regard to hormone replacement therapy. So this was again in 2015, Obstetric and Gynecology International Journal, and they looked at WHI study, but this time in women 50 to 59 years of age. Remember, only 30% of the participants were in this age range, and even with the wrong type of hormone, the result was not as bad as they initially presented. This is the Journal of Climacteric in 2018, and it says that estrogen with micronized progesterone do not increase breast cancer risk up to if you use it up to 5 years. If you use it more than 5 years, it can be even protective against breast cancer. And the French E3N study, this is what they said. If we continue the right type of hormone replacement therapy with micronized progesterone, the relative risk of breast cancer decreases when we continue hormone therapy beyond 5 years. A French E3N study was a large study that is credible, and it's the study comparing conjugated equinestrogen with transdermal bioidentical estrogen. And there are two other very interesting results from this study. This was published in April 2019 in International Journal of Cancer, and it shows that when they check the blood level of the man-made chemicals named PFAS, they showed a linear association between the level of this chemical and breast cancer. And this is why in my intake form, I ask every woman, do you use Teflon for cookware? Do you use food packaging, plastic food packaging, plastic food container for storage, or do you put plastic container in the microwave or the freezer? Because if it's microwave safe, means that it's safe for the container, not for our body. We can get breast cancer by using plastic containers, and also we pollute our environment on top of that. So pre and polyfluoroalkyl substances, these are man-made chemicals. In food packaging, when we have nice furniture that we put protection against the stain and fire, different type of clothes, fire resistant, these are the chemicals that we get exposed to. It's even in our drinking water, in every living organism, because it's in our environment. We made it chemically and we put it in the environment, and we get breast cancer because of that. Because these are endocrine disruptors, and they can increase the risk of breast cancer. Another important note here from E3N study: artificial sweeteners, aspartame, increase the risk of type 2 diabetes, increase weight, and therefore increase the risk of breast cancer. Not to mention that aspartame is toxin to the brain as well. These are facts that every woman should know. When we avoid environmental risk factors for breast cancer, we can help ourselves to protect ourselves against different type of cancer and different type of disease. Regarding Alzheimer's disease, this was a study done in Finland on patients who had established Alzheimer's disease, and more than half of these patients were over 80 years of age, and they used the hormone therapy in these patients with Alzheimer, and the result was not to favor hormone replacement therapy because the design was wrong to start with. This is Australian Menopause Society, and this is their statement, the recent statement. It says, if menopause hormone therapy is to be used in a woman assessed to be at high risk of developing deep vein thrombosis, a transdermal preparation should be used. In my opinion, every woman in older age is at risk for clot formation, and when we have a safer way to provide the hormone, get more benefits and less side effects, it is not rational to use the oral estrogen. This is from Public Library of Science journal, PLOS 1 in 2014. And they also mentioned that only transdermal estradiol showed protection on hallmark area for early degeneration in Alzheimer's disease. In other words, using transdermal estradiol is protective against Alzheimer, it's protective against brain damage, and not conjugated equinestrogen. So there is no reason to use oral estrogen or horse's estrogen. This was a study done at many organizations like UCLA, Stanford, UC San Francisco, and many other ones. And they chose women at risk for Alzheimer who had ApoE4 positive or family history of positive, and they compared transdermal estradiol with conjugated equinestrogen. And also they used medroxyprogesterone acetate, and it showed that medroxyprogesterone acetate decreases the metabolism in the temporal area in the brain, and it's harmful. And actually, transdermal estradiol reduced amyloid compared with conjugated equinestrogen and placebo. These are very important scientific results that we have access to if we search for it. It's not coming from out of nowhere. It's all credible scientific resources. There were 2 studies, randomized trial studies, on women with Alzheimer on transdermal estradiol, and they showed significant improvement in attention, memory, and function. And when they stopped transdermal estradiol, the memory quickly declined. And this is why we need to continue hormone replacement therapy as long as we need to. And women should have the choice to continue that as long as they want to have a better quality of life. JAMA 2017, it says Again, even in WHI study, when they looked at women 50 to 59, after 18 years follow-up, there was decrease in all-cause mortality. Breast cancer research, they had a study on estradiol, estradiol with micronized progesterone. When we say P4 means micronized progesterone, which is bioidentical progesterone. And medroxyprogesterone acetate is not bioidentical and is the one that causes breast cancer and damage the brain and many other side effects. So they noticed that when we use medroxyprogesterone acetate, there are increased in markers of cancer. Ki67 and cyclin B1 are two major markers of cancer. And when the patient has cancer, we check those markers to see how active the cancer is. And there was increase in these markers when they used medroxyprogesterone acetate in monkeys. And in this study, when they used the micronized progesterone, there was no increased risk of breast cancer. This is a very interesting study. It was published in August 2019 from Frontiers in Endocrinology. This study shows that 17 beta estradiol, the bioidentical estradiol that we use, actually helps to prevent type 2 diabetes and therefore decreases the risk of breast cancer for the reasons that I explained. Why, when we have extra fat, we convert androstenedione during menopause to estrogen and increase risk of breast cancer. How can we decrease the risk of breast cancer? We should avoid alcohol as much as possible. Why? Because alcohol is a toxin. When we drink alcohol, our super antioxidant glutathione, which is the major source of detoxification, becomes busy detoxifying alcohol. So during that time, estrogen, E1, has the opportunity to convert to quinones because there is no glutathione to detoxify, and increases the risk of breast cancer. We need to avoid xenoestrogens in plastic containers, cosmetics, hair dye, chemicals, BPA. Every receipt that we get from any store, when we touch it, it has a layer of BPA powder on it. When we touch it up to 4 hours, it's on our skin. Even if you wash your hands with soap, you cannot get rid of BPA. BPA, like many other chemicals and xenoestrogens, is endocrine disruptor, and it increases the risk of breast cancer and many other side effects. Estrogen dominant. In younger women, it can cause endometriosis. It can make endometriosis worse. We need to decrease the level of E1, the bad type of estrogen, by eating cruciferous vegetables and also taking supplements containing indole tricarbinol, DIM, and CGD, which are the enzymes to detoxify estrogen. And in my practice, if the patient is able to do the genetic testing and can afford it, definitely I do the genetic testing before starting hormone replacement therapy. Exercise also helps to prevent breast cancer because we increase endorphins when we do exercise, and when we have increased endorphin level, any cancer cell who is dividing exposed to endorphin will die. This is how we fight breast cancer with exercise. And another way is checking the metabolites of estrogen in urine. In every patient, I check metabolites in the urine. In menopause patients on hormone replacement therapy, or younger women when they have estrogen dominant, endometriosis, polycystic ovarian syndrome, because we need to know how our body manages the estrogen. The metabolites are mainly three types: 4-hydroxy, 2-hydroxy, and 16-hydroxy. 2-hydroxy is the good type. the 4-hydroxy is the one that converts to quinones and causes cancer. 16-hydroxy, we should have a certain amount of 16-hydroxy because it's the main protection against osteoporosis. But too much of that also causes breast cancer. So this is why we need to check the metabolites of estrogen on these patients. And also make sure we have enough glutathione. If we have glutathione deficiency, we need to replace that. And this is again about hormone replacement therapy that I already mentioned. This is the statement in 2017 from North American Menopause Society. Even in their statement, they say hormone therapy does not need to be routinely discontinued at age 60 to 65. Routine discontinuation of hormone therapy is not supported by data, and transdermal estrogen may be safer. Well, I can tell that transdermal estrogen, based on many scientific evidence, is safer and more effective. And this is Climacteric 2016 that says there are no reasons to place mandatory limitation on the duration of menopause hormone therapy. Again, I showed you studies showing that continuation of hormone therapy beyond 5 years is even protective. And this is another meta-analysis, but also in this study, they say that half of women who have breast cancer, they never had hormone replacement therapy in their life. So why should we scare women from breast cancer and avoid hormone replacement therapy? Also, in this study, they use progestins. Progestins are not bioidentical, therefore the result is not valuable in our practice. Because of the limited time, I cannot go over these slides, but hormone replacement therapy has so many benefits on bones, muscles, brain, heart, vessels, urinary tract, sex life, cartilage. Hormone replacement therapy can actually help with cartilage damage and knee replacement. And also, there are studies showing that estrogen hormone replacement therapy helps with the texture of the skin, decrease the wrinkles and appearance of the skin. Definitely on cardiovascular disease, there are many benefits if you use the right hormones. And there is one last thing that I want to mention, that you can actually pause and read these slides. These are important. Also, when we optimize hormones, we check testosterone, diepiandrosterone, dione, and DHEA on top of estrogen and progesterone and different type of estrogen, because we want to optimize all hormones, even testosterone in women. And again, the Cochrane review was based on WHI and HERS study that are not designed the right way. Yes, hormone therapy can prevent and help with the treatment of type 2 diabetes. We don't have to stop hormones at certain age. And this was all the study. In this study, they did not even mention what kind of hormones they were using, and it was published in JAMA. These are most common type of SNPs causing breast cancer that we can check. And how can we decrease the risk of breast cancer? Again, using the right type of hormones, checking for specific SNPs, eat vegetables, green vegetables, organic food, no GMO, no processed food, no trans fat, no extra fat, keep normal BMI, and yes, insulin resistance and diabetes increases the risk of breast cancer. And normal, healthy microbiome in the intestine is also important for the reason that I explained. Definitely optimizing the vitamin D level, avoiding xenoestrogens, avoiding alcohol, smoking, and doing the screening test. And there was a nurses' health study showing that nurses who had night shift had higher risk of breast cancer, and many studies showed the relationship between protective of melatonin against breast cancer. So in my practice, every woman who's on hormone replacement therapy is advised to take melatonin, and even patients with breast cancer would benefit from taking melatonin. Not only it helps with the sleep, also it helps to prevent and protect breast. This is a book that I recommend every woman to read. It's very well done by Dr. Blooming, who's an oncologist, a revolutionary oncologist, and this is an excellent book and everybody should read it. Although I don't agree with everything that Dr. Blooming says in this book, including his opinion about oral estrogen. He encourages women to take oral estrogen because the studies were done on quilin, which is the horse's estrogen, and Alzheimer. But as I showed you, there are many studies showing the benefit of transdermal estrogen on Alzheimer and brain protection. And I hope this helps you to make an informed decision. If you have any question, you can email me. My email address is on my website. And I hope you all have a happy, healthy life with the best quality of life as long as you live.